This conference will now be recorded.
Good evening, everybody. This is John Antonucci. This is high-risk recurrent metastatic prostate cancer discussion group at AnCan for 23rd July, 2024. We're going to get started in a minute. I just want to acknowledge some of our sponsors, without whom we would have a hard time paying for all this, and who require no endorsement of their products on our part. And they are Bayer, J&J, Myriad Genetics, Telix, Blue Earth Diagnostics, Foundation Medicine, and Novartis. I want to switch my view over to everyone and see if there's anyone on the phone. And I don't see anyone on the phones right now. Now, there's nobody new here, is there? Okay. Before we get started, Rick has something he wants to announce for us.
I do. Can I just say, Larry, we're getting, Mr. Fish,
Yes.
we're getting some strange feedback from you. It sounds like your pipes are grumbling. Are
Maybe
your
it's my air
pipes?
conditioner.
Oh, it could be, but we can hear it. So mute and then come on off mute when you want to say something, if that's okay. Or put your hand up. Or both. Yes, I do want to say something. Sadly, not just one man down, as you might have seen in my reminder, which the circumstances of which are very, very puzzling. I can say a few words on that in a minute, but another man down who many of you know, and I heard about this, I think it was Monday morning. We lost Jim Barnes last weekend. So I'm very saddened. This was a young man, 65, who did everything that he thought was right, but he got dealt with a hand of two tumor suppressant growth genes, PTEN and TP53. Maybe others too. Maybe others too that might have played into it. And once he chose that Pluvicto route, and he took a lot of time to go through the alpha and the beta, or the beta and then the alpha. He didn't have enough breathing space to really go to the treatments that might have gotten to it. And I'm just hoping that now that we know that those Pluvicto treatments are sensitive to certain mutations, we can encourage men to make the decision to go on Pluvicto in light of whatever mutations they carry. So, just a lot of respect. A lot of us cared about him. I know we have a very light evening in terms of people wanting to speak and no new people. So if anybody would like to say a few words about Jim, I'd encourage you to do so. I know, Peter Monaco, you and Jim spent quite a bit of time on, what's it called, Ireland, wherever it is,
Marco Island.
Marco.
Yes, we had lunch together several times, and I didn't know this, Rick, and I'm very saddened to hear it. He was a very good man, such a nice guy.
Yeah, it will go in the reminder, but I found out after the reminder had been sent this week, so it will go in the reminder this coming week. Anyone else? Len, did you want to say anything?
Sure. I had the privilege of meeting Jim in person
but I certainly have met with Peter Monaco, and I trust his judge of character. If Peter says he was a real good guy, I take him at his word. I believe that. And as Rick said, it's a shame that someone who normally would be starting his golden years, 65, ready to retire, and it just unfortunately didn't happen. He always appeared to speak very matter-of-factly about his failed trials, never showed any signs of self-pity or anything like that. So I admired him for that. And I'll miss him.
Yeah, he was a very classy kind of guy. Just you could tell he was from a very good background, and he was very intelligent, and obviously had a very good career. And he was a real pleasure to spend time with. I'm glad that I think Len, it might have been you who told me to reach out to him because he was going to be in the area where I was spending my winter a couple of years ago, and we
Yeah.
wound up getting together about 3 times. It was always a pleasure. Although the last time I saw him, he had just gotten back from, where did he go? Sweden, Germany.
In Europe, yeah,
And
Vienna.
you
Austria.
know, he was hopeful. He had gotten a good PSA test, and he was hopeful that this would be the thing. And then I saw him give some updates at this meeting, and the treatment obviously didn't help. And I felt very, terrible for him. And again, it's a shame. He was a really good man, and he's left us too soon, 65. He had a granddaughter, I know, and it's just sad. Sorry to hear it.
Well, I'm sorry to be the bearer of bad tidings, and it happens too often. The brief words I wanted to say about my own friend who chose never to participate in the meetings, but talked to me very often, read the reminders, watched a lot of the meetings, was that he had um, he had strange prostate cancer. He was diagnosed in 2010 with a 4+3, but with seminal vesicle invasion. So it was an 11 out of 12 cause positive. So it was never a good diagnosis. And he chose to do high dose brachytherapy, IMRT, and hormone therapy. At that time, it was just simply Lupron, which is what I was doing. I had a very similar treatment recommendation. For whatever reasons, he only did 6 months of hormone therapy because he couldn't maintain his high profile job and on the hormone therapy. He actually retired in 2016 because he had to do chemo because the disease came back, and his PSA had gotten up to 20 because he'd been putting off doing any more hormone therapy, and he went back onto chemo and hormone therapy. And that really was pretty successful for him, very successful for him. He had outstanding medical oncologists, I think. Um, and he always managed his PSA well, and his PSA was never high. I mean, it was like 0.2, 0.3. I mean, it was. He went on holidays, and when he went on holidays, when he got up to like around 3, he'd start again. But in 2020, he was diagnosed with Parkinson's, and it's accelerated fairly quickly. He found that he needed treatment again. He went back on hormone therapy, but he came off of it. He was on holiday. And the last time I spoke to him, which was on St. Patrick's Day, his PSA was, I think, 0.08. And it was reported to me last week during Speaking Freely, which was why, if you were on there and you heard me say, oh my God, it was because I read the news and I didn't realize my microphone was on. I read the news that he died, evidently from prostate cancer. Evidently, he had some type of prostate cancer, which doesn't make PSA, and it was all over his body. And the oncologist said, well, I don't know what oncologist, but his wife said the oncologist said what we want to make sure everybody hears is don't just measure your PSA, get a PSMA scan every year. The problem was his damn oncologist, who isn't somebody I particularly care for, and he doesn't care for me, and we have a very long history going back to 2010. And it wasn't Nigel's original oncologist. His original oncologist was Chuck Ryan, but Chuck Ryan moved on to other pastures. His original oncologist always refused him when he asked for a PSMA scan because he said his PSA was too low. So I don't know. I do know, and maybe others of you have heard of this, but I do know that I've never heard of somebody with very, very, very low PSA having cancer all over their body, because even the guys with neuroendocrine, at the end, their PSA goes up. I mean, it doesn't go up for the longest time, but when it does go up, it goes up and we can't bring it back down again. And we've had plenty of guys like that. And maybe it doesn't go into the thousands, but it goes up towards 100 and it gets out of line. So I don't know. And like I say, it's been very upsetting to me, and probably one of the reasons being that I have no closure with a very dear friend. But it's a strange story. What can I say? So, unless anybody has any questions or comments, we can.
Rick, I have a question, Rick.
Yes.
If you found out or someone found out he had it ridden throughout his entire body with such a low PSA, how did they make that diagnosis? On autopsy, or did they eventually get a PSA scan?
No, they at some point they don't ask me how, because I don't know. I don't have any details. I didn't speak to him since the 17th, and it's only what his wife sends me. But at some point they must have done the scans, and they must have figured out what was going on. And I don't know how much his PSA went up, and it might have gone up in those last 3 months, but I don't know how high it could have gotten in that 3 months. But I mean, on the last PSA I have for him was in 1023. It was 0.077, and we spoke on 116 and 317, and I didn't make a note of his PSAs, but they weren't very high, because otherwise I would have made a note, because he was always asking me, what, but if it goes up, what should I do? And so that's it.
So sorry, Rick.
Okay. Peter, I know you just got stunned by some bad news. Do you still want to bring up what you were going to bring up?
Yeah, I mean, I'll be brief. A couple of weeks ago, I reported that I was going for spot radiation to treat a lymph node somewhere in my paratracheal area. And originally, I had scheduled it to sometime in late September, mid-September, and Rick suggested I might think about moving that up. So I just want to let you know that I did. I worked it out with
Oh,
the doctor, and I will be going in early August for the treatment. 5 sessions. He had to lower graze. I think that's the thing. Um, because I'm on blood thinners and it's in an area where it's kind of close to the lung, and he didn't want me to be bleeding, so he thought he could lower it enough that it would still be effective. So I'll be doing that at the end of next month.
It's going to require
Otherwise,
some really careful aiming, isn't it?
yes, yes. Uh, he doesn't want me bleeding, particularly into my lungs. So that would be real bad. So it is a little bit scary, but he thinks that it would be worth it. It would knock off this lymph node at least partially or mostly enough that you know uh, I might be able to go longer on just the treatment I'm on now, which is no Nubeqa only right now.
Yeah. Who's your radiation oncologist?
His name is Jonathan Stewart. He's with
Stewart.
Mount Sinai. I was referred to him by my oncologist, Dr. Patel, also with Mount Sinai.
Is it an MRI guided or a CT guided SBRT?
I have no idea. I probably should know that, but I don't.
Yeah, I believe it's IMRT. I don't think it's this is not like, as far as I know, like radiation to the prostate.
No,
Um,
no.
no, this is just so. I have not heard about them using the Meridian type of equipment for spot radiation yet, although it's possible. And Len, have you or Dr. Wassersug, have you heard them using the type of Meridian type of stuff for spot radiation?
I had a choice.
I can't give
Did
you
you?
an update from the Canadian perspective. We're lucky if we get radiation up here.
I had a
That's
choice, Rick, between the two. I had a choice between the two, and I was tattooed for MRI guided Meridian. Except
Okay,
I had a problem with my shoulders, adhesive capsulitis, where I couldn't keep my shoulders, my hands up in that little tube long enough, so I had to get it done by CT guided. I was disappointed. I asked him, could you tie my hands together? He said, no, you can't. You can't do that. So, but they do have it available at Sylvester.
okay. That's really good to know, Jack. I wasn't, we weren't aware of that. I'm pretty sure that what Peter will be doing is just regular IMRT, not even SBRT.
Oh, really?
It's 5 sessions of IMRT.
Right. So that's all I had, John.
All right. Well, we'll be real interested.
Thank you.
Richard, did you start to say something and got cut off, or did you finish saying what you were going to say?
you're talking to me? Yes.
Yeah.
Okay. So, no, I just said it's interesting to look at from my perspective. For all of you don't conceal my name, I'm based in Vancouver, Canada, and we have limited resources. You get whatever you can get, but I mean, there's a limited number of centers that have
Yeah.
these options, and most of the places don't. You simply have to use what equipment they have. The U.S. is way ahead of us in this regard, but I don't have anything I can add to that.
Okay. Okay, Peter. Thank you.
Thank you for listening.
I got Paul Frieda next. What's on your mind, Paul? Gotta unmute. Yes, you.
I think he's frozen. Is he frozen?
No, his picture's moving. Paul, can you unmute? Oh, there we go.
I was muted. I had to unmute.
Okay.
After 5 years of remission, last November, my PSA went to 0.13, and it's behaving very strange now over the last 7 months. It went from 0.13 to 0.17, and then looked like we're going to have to do something, and then it dropped to 0.15. And we waited a couple of months, and then it went up to 0.3. And so I got sent to the proton therapy unit at Delray Beach Hospital, and after a PSMA PET scan, and there was one bright spot near the bladder, and I chose not to do the 40 treatments of proton therapy. I wanted to be sure that I really needed it, and the the radiation oncologist was very honest with me. He said it could be a false positive, and he can guarantee that he couldn't hurt the bladder. So we waited, and then waited 2 months and did another PSMA, excuse me, another PSA, and it stayed at 0.3. And so that was 2 months. So we decided to wait, and I just yesterday found out that after another 2 months, it's still at 0.3.
Ah,
So it looks like it's going to be in a waiting mode for a while. Um, and my oncologist said that we kind of wait until it doubled in 3 months, and then I might jump back on Lupron, which was very effective for me for 5 years. So that's where I am. At first, it looked like I was in really bad shape, and now it's behaving very well controlled. My testosterone is still quite high. It's up around 200, but doesn't seem to be causing the cancer to grow. So I don't know what's going on, but I'm happy that it's slow moving and behaving nicely.
yeah, if you're going to have a recurrence, this is the way to do it, isn't it?
What's that?
This is the way to do it if you're going to have a recurrence. And it's going to keep you on pins and needles, but still the idea that it's just sitting there right now
Yeah, it's sitting there
is
at 0.3.
is pretty
We'll see
good.
what happens. We're going to
What
wait
was your
3.
original Gleason score, Paul?
Oh, my Gleason was started at 3.4, but after the surgery, it was at 4.4.
So you're a 4-4, then it's stayed in remission for 5 years and now is behaving fairly indolently. Good.
It's come back, but it seems to be very well controlled and mild. The 5 years of remission was after 3 years of Lupron. So
Yeah, yeah,
and
yeah.
I didn't have radiation after the prostatectomy. That was a tough decision, but I decided not to do that. And so I'm consider myself a pretty lucky guy. I mean, been going a
Yeah.
long time and being well controlled. So hopefully that'll continue.
Now, how do you pay for your proton therapy?
How do I take what?
How do you pay for your proton therapy?
I'm still not understanding what you said. What?
Payment, finances for
Payment?
proton? Yeah.
Oh, well, it was a very nice proton facility at Delray Beach Hospital. They have their own building, gorgeous new building, and it's my understanding they're quite busy.
And your
But
insurance will pay for it?
what?
And your
Will
insurance
your
will?
insurance pay for the proton? Will your
Where do what?
insurance pay for proton?
I never got to the point of finding that out. I got the impression, but I did inquire, and the lady said I would pay $35 every treatment time.
Wow.
So yeah, so I have Humana Advantage, and she got my card, and she went on the internet, and then she said I would I would be at 40 treatments, I would pay $35 every time I came in for a treatment.
Anybody else had proton therapy? Okay.
No one's had
Well,
proton. There's somebody I remember did, but I can't remember who it was.
it's kind of nice to know that somebody was willing to pay for it. Does Medicare cover proton therapy? I don't think so, right? It
Yeah, it
does,
does.
Rick?
Yes, they
Oh,
do. John, I had proton therapy,
yeah.
and at Mayo in Phoenix, and I wasn't charged anything.
Okay. Okay, I was wrong about that. Well, I'm pleased to hear that. That's nice.
Yeah. So
Anybody have any reactions to what Paul had to say? I hope that's what happens to me when my recurrence comes around.
I
That's
think
John. It's Len. That happened
Hi.
to me years ago when my PSA seemed to be on the march, moving up quickly from below zero point 0.1 to 0.6, and then it just plateaued there for about 6 months. But then once again, it started up again. So yeah, like you said, sometimes it just goes into an indolent mode and something wakes it up
And you sat there at 0.6 without treatment?
without treatment
Ah,
well, this is at a time when there was no PSMA PET scan.
yes, I understand. Okay, very good.
and I'd just like to make.
Go
Go
ahead,
I
ahead.
had
Rick.
one thing. My
Go ahead,
oncologist said
Paul.
something. My oncologist said something that surprised me. He said that if it comes back, when it comes back, I would go back on Lupron. And he said that, but after a year, he would take me off the Lupron and see if we got another remission. That surprised me that I might get a second remission. So, hopefully that'll happen.
Yeah, but Paul, you've heard guys here all the time on intermittent hormone therapy, right? You've heard us talk
I
about
had Lupron for
intermittent
5 years,
hormone therapy.
shot every 3 months.
Sorry?
For 3 years after, well, after the surgery, I think it took about a year for the PSA to start to rise, and then I went for 3 years with a Lupron shot every 3 months,
Right. But what I'm saying
and then
is you've heard people on this in this support group talk about intermittent hormone therapy, right? So you going back on hormone therapy and then stopping after a year shouldn't surprise you because that's intermittent hormone therapy.
well, I really don't know, what to expect. So, I thought that I didn't think that I would get another remission, but
Hmm,
he said that there's a good chance that I would get another remission after
you
about a
might.
year.
Yeah, you might.
Yeah, yeah, I think there's a good chance. But the one thing I wanted to bring out, which is really interesting, doesn't really have much to do with the cancer, but it brings up a really good contrast in the difference between an advantage plan and a supplementary plan for those of us who are in the United States. That advantage plan is probably costing Paul, if it's like I am, it's costing Paul very little each month. What do you pay each month for that plan, Paul?
$10.
$10. Now, if Paul was on a G plan, he would have no copays, but probably be paying somewhere around $400 a month.
Well,
So
that's what I was paying. I was paying Mutual of Omaha $400 a month for a long, long, long time,
that's right.
but then I never had to pay a penny.
That's what
When
I
I went
just
in
said.
for anything. But the
That
Medicare Advantage, there are certain things that it won't cover. So there's a point going down the line where I may be sorry that I switched.
So what I wanted to bring out is maybe it's going to cost Paul, if he were to do 40 sessions of proton, $1,800 or something like that in that region. I got to do the math. 40 times 35, whatever that math is, $1,500. Maybe it will cost that, but at the same time, he still comes out ahead if you look at it over the year, because he'd be paying $4,800 a year if he was on the G plan. Now, I personally am on an Advantage plan, and what I did is I looked at that Advantage plan and saw what my maximum out of pocket could be. Maximum out of pocket, even if I went out of network. There's a maximum out of pocket. and I compared that to what the G plan would cost me. And from that I could decide, did I want to roll the dice? And I think it's something like $7,800 versus about $5,000 is what I would have been paying for my G plan. So I said, you know what? For $2,500, I'll roll the dice. If I lose, it costs me $2,500, and if I win, I'm going to save like $5,000. So this is just a little bit of education in Medicare economics when you choose your plan. And it's a really good example. And Paul Frieder is a really good example.
Well, there's another unexpected wrinkle in the insurance area. When I had my prostatectomy, it was, okay, first, Medicare, I signed up for Medicare late, for Medicare B. And when you sign up late, they increase your payment. But what they also do is they won't cover you for 18 months. And when I had my prostate surgery, it was inside the 18 months. So Medicare was not going to pay for my prostate surgery, which was $45,000. So I went to the finance office of Memorial Sloan Kettering, and because I'm not a very wealthy man, they found a charity that paid for it, and all I had to do was pay them $300 a month for a year.
Nice. There's the penalties
So in
for
other words,
signing up for Medicare.
there's other alternatives if your insurance company thinks out on you.
Penalties for signing up late for Medicare are very severe.
I'm not sure. I think I was just an oversight or something like that. I didn't realize how important it was to sign up at the same time.
Yeah. Yeah. We have the trickiest system in the world, I think. Okay, Paul?
That's it.
Okay. Hi, Steve. I got you up next. What can you update us on?
Well, a week and a half ago, I had my third Provenge infusion and ended up with blood clots in my lungs, blood clots moving through my veins immediately, and then ended up in the hospital the next day with blood clots in my lungs. And understand it's a known hazard with the Provenge and immunotherapy in general. And I wasn't at all sure that the people giving me the Provenge understood that. But yeah, just want that to be known.
Didn't you also have back pain?
I had back pain at the first infusion, yes.
Oh, okay. So tell us about this side effect again. What happened in your lungs, as specifically as you can, because we want to be able to look out for it for anybody that goes through Provenge.
Yes.
How did you know that you were having the problem? Were you short of breath or spitting up blood or what?
Yeah, short of breath, very short of breath. By 2 days later, during the infusion, I actually felt lumps moving through my veins and seemed to stop at the check valves sometimes, and I could feel the pressure, the veins swelling and the pressure increasing. Stopped the infusion for a while, and they actually ended up finishing the infusion, and then a day and a half later, I was having trouble catching my breath and ended up going to the ER, and they did a CT that identified the blood clots, and then some no
Heparin?
Oh, and they put me on Heparin, and now I'm on um, a more modern blood thinner.
Yeah, clopidogrel or something like that.
Equus,
Ye-
Octus, something like
Yeah,
Equus or something like that.
yeah,
So 2 days after your treatment, shortness of breath.
yes.
And is that it now for Provenge?
Yes, it's a 3 treatment session, and I got all 3 in, and
Oh,
I understand that even though I had the reaction, um, they've studied it enough that they know that even people who have had the reaction can get the benefit from the Provenge. So
okay.
uh, I've still got that possible benefit.
Okay. See, we're learning a lot of good things tonight, aren't we? Okay. Is that it then? Any comments, questions? Anybody else been on Provenge?
I think this is, we've been seeing guys get Provenge for years,
Yeah.
years and years. I mean, since probably 2000, certainly since 2015, and I'm pretty sure even before. I just can't think who offhand. I don't think we've seen this blood clots issue before, but I may be wrong. We could have done, but I don't think so. So this is a we thank you for bringing this back to us, and we will make sure going forward that people are well aware.
Is it possible that the clots could occur in the brain or the heart?
Um, it's my understanding that where the clots form, uh, they flow to the lungs and get with the smaller vessels at that location, they end up blocking or slowing blood flow at that point,
Oh, I see.
yeah.
So
So
these were
especially
clots
the
that
right
formed,
ventricle, I think it is.
these clots formed elsewhere in your circulatory system, went up the veins into the heart, out to the pulmonary artery, and that's where how they got into the lungs.
Yes,
And that's why they couldn't get to the heart or the brain because the lungs filtered them out, right?
correct. That's my
Okay.
understanding.
So you were in some sort of a total kind of hypercoagulable state with some consequences. I see.
And
Okay.
it, well,
How do you avoid a stroke when that happens?
To have a stroke, the blood clot would have had to occur in a different place, someplace where it could then go through the
To the
other
brain.
side of the heart, the left heart, and then
Ah,
get up into the brain. And usually those clots happen someplace like the atria of the heart on the left side, and they can flow right into the brain from that spot.
So infusions
And
on your
How are you feeling now, Steve?
feeling okay. I went for a short walk today and started feeling a little bit of shortness of breath, nowhere near as bad as originally. And so I guess I'm just planning on taking it easy and progressing a little bit. I don't want there to be a big pressure differential built up in my heart um, from the blood clots on the one side and cause damage that way. So, uh, yeah, I, I'm thinking over the next month or two, the clots should end up going away. and I'll start pushing myself a little more after that. Hopefully, there's another scan that can tell me whether the clots are gone or not.
Yeah, you can get scanned for pulmonary embolism.
Yes.
Rick?
Yeah, I was going to say to Steve that you might want to talk to Dr. Yasevsky as to whether, given the clots and the heart issue, whether he thinks you should stay on the abiraterone and prednisone, or whether you should switch to a one of the Ide brothers.
Okay. I will
What do
ask
you?
that.
I mean, what does the group think of that? Because we're all aware of abiraterone maybe not being the best for people that have heart issues, right, Jeff Marchi?
It causes heart issues.
You want to follow that up with your own comment, Jeff? You have your hand up.
Steve, did they put you on a blood thinner?
Yes,
Yes.
Eliquis.
Eliquis.
Yeah,
Eliquis.
I was on heparin in the hospital, and then they put me on Eliquis, and I'm going to be on that for at least several months.
And it has not completely resolved the blood thickening, probably, but you still have problems with your blood not being thin.
No, I think the blood is thinned. It's just the clots are still there, blocking the flow in my lungs.
And the body
Okay.
gets.
Okay.
But implied in Jeff's question is, are you still going to be hypercoagulable in a few months? And I think the answer is no, because the Provenge will be long gone and worn off.
That's what we were.
I hope.
Yes.
Okay, thank you, Steve. I have Alfredo next.
Well, good evening. I had to get unmuted there.
Now
Just to
that
get a,
Rick has given you the bad news that you're welcome to this club.
it's good news. Good news. I'll just do a few sentences to kind of get up to speed and then talk about recent events. So, without going all the way back to my first elevated PSA, which was quite a long time ago, something like 14 years ago, in 2020, which is not that long ago, I went down to Galveston, Texas, and had a focal laser ablation there. In terms of the logistics of the procedure, it was actually pretty good. It's an outpatient procedure. You go home and have dinner with the grandkids. It brought my PSA down from 23 to 3. That's 6 months after the procedure. And we thought, oh, well, that's good. And the MRI, 6 months after the procedure, looked really good, looked really normal. So now a few years have gone by, and beginning of this year, my PSA went up to 10.6, 10.7. And we said, okay, now it's time to do something more definitive. And since my encounter with the intermediate group, AnCan group, where we talked about some options, a lot has happened. So my regular urologist, who I will describe as a community urologist, said, sure, you can get a second opinion at MD Anderson. And I did there with I thought I had an excellent visit with another urologist there named Brian Chapin. And then I said to Dr. Chapin, actually his fellow came in the room and said, you probably want to talk to radiation oncology before you make a choice. And the surgeon totally agreed, said, I think it's a great idea. I met the radiation oncologist. His name is Dr. Choi. He happens to have an MIT degree in nuclear engineering, which I thought, oh, that's interesting. And he has recommended, and I'm gathering now that this is pretty standard for many prostate cancer patients. I started Lupron yesterday with a 3-month injection. I started Casodex yesterday. And in about 2 months, we'll do some blood work, and then I'll have IMRT with 40 or 45 treatments approximately for 2 months, and then we'll see what happens after that. So that's my story. I just wanted to mention an aside because it came up earlier about a false positive with a PSMA. I had a PSMA in about April, and it was interesting because there was an area that lit up. The good news is nothing lit up outside of the prostate. The potentially bad news is that there was an area the size of an almond or a grape that lit up quite prominently inside the prostate. And so 2 of the doctors in my story, the guy back in Galveston reviewed that scan, and Dr. Chapin at MD Anderson reviewed that scan, and they both felt that what was lighting up in the prostate was not tumor, but actually was a cyst. And a way to think about this is that with all the poking around inside my prostate with the catheter that did the biopsy and the focal laser ablation, some cystic areas have been created, and the PSMA, the radionuclide, collects in there. So that's a way of having a false positive that I really had not been familiar with before. But anyway, no one is concerned anymore about that PSMA, and the plan now is the hormone and the IMRT, as I described. So that's my story in a nutshell. So I guess the only thing I'm thinking about today is about the Lupron and the Casodex. What can I expect in the next couple months before I show up to get the radiation treatment?
Okay, great question. Let me catch up just a little bit on you. What's your age?
70. I'll be at 71 in September.
Where do you live?
Houston, Texas, and Wimberley, Texas.
Oh yeah, we were talking about that. And you were diagnosed in 2010.
Well, yeah, I mean, you could say, is the diagnosis the very first time my PSA was outside the normal range? Or is
No,
my
it's the
diagnosis
very
the very
first time
I
you
had
got a biopsy that confirmed
2015.
2015. Okay. And that's when they did a biopsy and confirmed that you had prostate cancer, right?
Did an MRI guided biopsy, and 2 or 3 needles were positive, and they were Gleason 3+3. There was no Gleason 4 at that time.
Excellent. Okay, great. So since that time, you were fine until you had your focal ablation in 2020.
And what triggered the focal ablation was we were monitoring my PSA, and it crept up to 23. And so we thought, oh, that's a good time to pull the trigger and do a treatment.
Okay, great. And what kind of machine did they use for your focal ablation?
I was in an MRI machine, and the chairman of radiology at UTMB in Galveston is an interventional radiologist. So his specialty is he can put a catheter anywhere in the body. And so he threaded a catheter up there, and there was a laser. I can't remember the brand name.
This was a laser? Okay.
Yeah, 2.4 gigahertz laser. So in a way, it's like putting a microwave at the tip of the laser and basically cooks the tumor. And he's watching it in real time as he does it.
And who's your treatment team now?
So I guess now that I'm at MD Anderson, it's Dr. Choi, C-H-O-I. His first name is Sengtaek, S-E-U-N-G-T-A-E-K.
Is that the radiation guy, or is that the
radiation? That's the radiation guy.
Do you have an oncologist also who's prescribing the Lupron and Casodex?
I guess he is. No, he is.
Oh, he's prescribing the Lupron and the Casodex.
Correct.
Right, the radiation guy. Okay.
And he started you on your first Casodex pill was the same day that you got the Lupron shot, Alfredo?
Exactly right.
That's a little weird.
Oh.
You know, normally it's given as a buffer. So it's given ahead of time because the way the Lupron works, it can cause a flare in your testosterone. So they usually give it as a buffer. So I find that strange that they started you at the same time. What was your PSA? What was your Gleason score when you went back in for the focal? Was it still 3+3?
3+4
Okay.
in one needle. And so then more recently, now with the PSA going up to 10.5, I had a standard trust biopsy, transrectal ultrasound biopsy. And that one was benign in 10 needles, 3+3 in one needle, and 3+4 in one needle. So that's the
Oh.
trigger for the radiation oncology.
You don't, you generally get graded by your worst, your worst measurement. So
Yes,
we'll call you a 3+4.
yes.
Did you
So
ever have to need genetic testing?
Back in 2015, when genetic testing was brand new, they sent off some of that tissue to an outfit in California. I think it was called, it's the people who do the test called Oncotype DX. Is it Genomic
Yeah.
Health, I think? Now, Genomic Health, the company, has merged several times with other firms since then, and I've never encountered another physician who knew what to do with that number. But they gave me a ranking of 9 on a scale of 100 and said, you're extremely low risk for prostate cancer. But that was 2015, so their database was not very big. That type of genetic testing was really brand new. No one I knew, urologist, internist, oncologist, nobody knew what to do with that number. And apparently nothing has changed because the various physicians I've been involved with more recently have had no interest in that number. I'm not saying it's a good thing or a bad thing. I'm just saying it hasn't been useful for anyone I know.
what about germline? What about testing to see if you carry any inherited mutations, Alfredo?
No one has suggested that.
You should
We
do
can,
it.
we can tell you how to do that quite easily.
Right. You should do it. I'm going to put a link in the chat window right now for a free inherited mutation trial that's being run by Johns Hopkins and University of Washington. They'll send you a cheek swab, and then they'll send it back. If they find anything, they'll arrange with a genetic counselor. It's called the Promise Trial, and a lot of our guys have done it. And if you follow through with it with this link, and they track it back, because we're probably sending more people to them than anybody, which is sort of interesting for us. It's something that really everybody who has prostate cancer should be doing. I never did it, but don't tell anybody.
Okay.
So I'm going to put that in for you right now. And Julian, how close is this to your story?
It almost follows it word for word.
Ah,
But I had a focal laser ablation down at UTMB also back in 2018, and I had a 3+4 Gleason score, and it after they did the focal laser ablation, it went from 6 down to 2.4 or 5, something like that. And it was like that for about a year. Then it slowly started creeping up to about a 6. And my urologist said, well, and it stayed at 6 for a while, but then it started creeping up again to 8.7. And I said, let's do something about it. That's when I had a fusion, MRI fusion biopsy, and they found a 4+4 until Hopkins looked at it and they went up to 4+5. So I went into Lupron and Beterone, and then met up with Dr. E, and she switched me over to Nubeca, and I forgot what the other one was. And about a year, almost 2 years now, I've been off of the drugs, so that's where I am right now. But it's almost the same path I'm on.
Well, I'm gonna suggest the two of you and Alfredo, swap contact details in the chat window.
Sure.
It might be a good idea.
I might have too much information.
You may. You just may.
Now
Troublemaker.
I'm going to ask somebody to tell Alfredo what it's like to be on IMRT since he's facing it in the fall. And then I'm also going to ask Rich Wassersug to tell Alfredo what it's like to be on ADT. And might as well plug your book while we're at it, because Alfredo might like a copy to know what he's getting in for and how to handle it. So would either Rich start off or somebody who's had IMRT start off and tell Alfredo what to expect, please?
Well, if I might chime in too, that's not all of my story.
Oh, I
That's
cut
not
you
all
off.
my
I
story.
apologize.
No, there was more to this because after that, I started that treatment with the Beterone and Lupron. I also had a high dose radiation brachytherapy boost that was done almost 3 years ago now. And then after that, I guess about a month or so after that, I had IMRT done, I think 39 sessions, and you had to have a full bladder and an empty colon, and that was rough, to say the least. So as soon as they were done, and it only took a few seconds, if you will, to do the rotation of the radiation, and then as soon as they were done, I had to run to the bathroom, and that was probably
Yeah.
only the best thing. 99% of the time, I made it.
So Alfredo, I think what Julian had might be similar to what it sounds like you might be about to have.
Sounds like it. Yeah. Yeah.
So you go over and over and over again for dozens of treatments. You have to go in with a full bladder so that you're a little uncomfortable, get a very brief treatment, and then run to the bathroom. And Julian, did you have any side effects from the radiation itself? Diarrhea or anything else? Julian, yeah.
I'm sorry, I was muted. But as long term, I think it affected my production of testosterone. But I don't want to get it. I rather, when I get to my session, I'll talk more about that.
Okay.
And Julian, was all that treatment at MD Anderson or somewhere else?
No, it was at Houston Methodist.
Okay. John, would you like me to comment
Yes,
now?
please. Please do, yes.
All right. So let me, I know a few of you, most of you I don't know. I'm based in Canada. I have been on, I'm a prostate cancer patient, had a failed radical, failed salvage radiotherapy, and did not like Lupron at all, and have spent a lot of the last 15 years or so studying the side effects of ADT. And in Canada here, we run a program. You're all welcome to look up the website. It's simply www.lifeonadt is one word, lifeonadt.com. And what this program consists of is it's an hour and a half, and this is for Alfredo, it's an hour and a half class on the side effects of ADT, what they are, how to manage them. And there's a book which John mentioned, and this is it. I don't know if it's showing up on the screen there. Get me that out of the way. Androgen deprivation therapy. So I'm the first author. This is the third edition. It is evidence-based, deeply evidence-based, in the sense that we've had it vetted by the Canadian Urologic Association and the Urological Association of Europe with a whole bunch of doctors. So this is not alternative stuff. This is how to manage the side effects. So Alfredo, I invite you to look up the website. And if we have room in classes, I just looked up, I'm teaching the next class on August 13th. We do let Americans in, but we can't give away the book for free. The class is free, so you could sign up. But since you've already started the drugs, I invite you to get the book. Not because I'm trying to sell the book, but because, and this is I guess in 2 or 3 sentences, the pitch here, and that is the side effects of hormonal therapy are manageable if you get to deal with them upfront early. If you wait till you have diabetes, metabolic syndrome, osteoporosis, depression, it's a little late in the game. So there are side effects. Some of them are serious you don't notice, dealing with liver function and such. There are side effects that you notice, like hot flashes, which can be very disruptive. But I encourage you to minimally. I'm sorry, it sounds like I'm selling the book. We actually argued with the publisher to keep the price as low as possible. I'm not trying to make money here, but I do encourage you to look into the book. And if you have a partner, to do it together. It's a workbook because indirect effect of these drugs, as our moods change, we gain weight, our appetite changes, and so forth, can affect our partners. So if you have a partner, both of you should look into it. And I could stop there, but I actually want to jump back one thing. One of the things I learned, Alfredo, you were the first person I've heard of who has gotten the Casodex and the Lupron the same day. And curiously, there's been one paper published about 2 years ago, which said, wait a second, this early use, like we used to get the Casodex like 3 weeks ahead of time, dates from a long time ago where people were being diagnosed because they had bone pain, they had advanced disease, and if they started on the Lupron without any Casodex ahead of time, they could get a bit of a bone crisis. But one paper suggested that there's not a particular need if they're being well tracked, and you are. But you're the first person I know who had gone over to this, or your physician had recognized that there wasn't a strong argument for actually needing to start it early if you are otherwise well controlled. I'll stop there, but I am a research scientist. ADT is my area of focus. We're trying to help people get able to manage ADT in its various forms by getting educated ahead of time. And we actually
well, Richard, I'll keep you posted on what happens with this. There's at least 3 physicians involved in this story who, I was unaware that Casodex and Lupron together was unusual. But because of scheduling, I did have to communicate with Dr. Choi and his PA and his nurse and my regular urologist about the dates. And I said, on this day, I'm taking Lupron and Casodex the same day. And so several people had the opportunity to go, oh, no. And none of them did. So it's interesting. I'll ask next time I can.
It is not the convention, but it's not inconsistent with what the newest data shows for someone in your situation, not at any particular risk. As I see it.
I'll just make one other remark, which I found interesting, not necessarily as an endorsement for MD Anderson, although I've been impressed with everything that's happened there so far, is that in the instructions they give you, there's a lot of details about parking. And you might think, why is that so important? And the reason it's important is they're doing 400 radiation oncology patients a day.
Oh my gosh.
So maybe that's a roundabout way of saying, I think they know what they're doing.
They do.
But I have to say, the people that I met at MD Anderson were the kind of folks that gave you confidence. They were patient. They listened to questions. They answered the questions. They made themselves available. So far, I've been impressed.
Yeah,
we do like MD Anderson, and I think we would be even a little happier if you had a GU medical oncologist on your team.
You're being well treated. My concern is not that I have anything to say that they might not have told you. It's just that a lot of us guys think I'll worry about those side effects when I get them. And that's a little late if you get diabetes. So this is why I encourage you to look into it. It's going to be pushing a lifestyle intervention. So I hope you're already exercising physically, because that's so beneficial all around for the ADT side effects. That's it. And if anybody has questions about ADT, I don't hide. John and Rick all know how to find me and so forth.
And Richard, can I order the book at the website?
Yeah, you can order it right from, well, actually, we don't sell the book. You can find it on Amazon. The publisher, just Androgen Deprivation Therapy is the name of the book.
Great. Thank you very much.
When the times when your treatment starts, they have what's called a tumor board meeting where they get together and decide on your treatment. And one of the things that they decide on is how long you're going to be on Lupron. Have they talked to you about that question yet?
No.
Okay. That's going to be a great question.
All I know, other than, of course, I communicated to Dr. Choi's team. I guess it's a nurse, a PA, and Dr. Choi, that I started the Lupron and the Casodex yesterday. And I received a reply actually just a little while ago. That's great. They're going to tell my regular urologist to order, liver functions and a few other blood tests. And then I'll have a phone appointment with the radiation oncologist in August, roughly a month from now.
So
Rick,
there's a
do you
very,
think,
there's
I was just going
something,
to ask you, Rick, a question anyway. Do you think Eleni would take him on?
well, first of all, I don't necessarily think that in my view, he doesn't need a GU medical oncologist at this juncture.
Oh, good.
Let's see how you respond, because this is a little bit different. I mean, the reason that Julian did was because he was a 4+4. It was more complicated, but with a 3+4 and this protocol, I think you're in good shape. I think that if you don't respond well, then we can talk to you about a genitourinary medical oncologist. That's a medical oncologist who specializes in prostate cancer. They have plenty of them at MD Anderson.
Yeah, I should say that my regular urologist trained at MD Anderson before he took his job at the big multi-specialty group here. So he knows Eleni and he knows Dr. Choi and Dr. Chapin. He suggested Dr. Chapin. His comment about Eleni was, I don't think you need, she's great, but I don't think you need a medical oncologist now. You don't have mets,
right?
You're not chemotherapy.
Right.
Go see the urologist, and let's see about that. So.
And Eleni's next door. He may not know, but Eleni's next door now. She left and she went next door to start up her apartment. And I'm actually going to be doing a keynote address, and we're all going to be meeting. Make a note of August the 7th, the evening of August the 7th, Alfredo, because we're meeting all of our Houston peeps. We don't know where yet, but we'll let you know for sure.
In person here in Houston?
Yes, in Houston. Okay. I will be coming in. What I wanted to say to you, which is really important, and I'm sure that Dr. Wassersug, he may want to comment. The length of time that you're going to be on hormone therapy is very, very significant in terms of what you can expect. If you are only going to be doing hormone therapy for about 6 months, which could be the case with a 3+4, a lot of the horror stories that you might interpret from Dr. Wassersug's book hopefully won't affect you, because a lot of the bad, not at all. I mean, I've seen people start and they immediately have horrible depression. They immediately have hot flashes, but it's rare. It's you usually have to be on the treatment between 3 and 9 months before it really beats you up. Is that a fair statement, Richard?
I'd add to it. Alfredo, you said you were 78 years old. Is that correct?
No, 70.
70. So one of the things on these chat lists and chat groups that's sometimes missed is that typically the younger you are, the more the drop is, because our testosterone is higher the younger we are. So if you go on these drugs, you get a big drop. But if you're a lot older, your testosterone has naturally declined and the change is less. So if I talk to a patient who says, I think I've had every side effect in the world, it's terrible, they're usually in their early 50s. If I talk to a patient, and I've talked to hundreds of patients on ADT, and they say, I don't think I'm having any side effects, they're usually in their mid-80s. So you may get some, but again, whether they're serious or not, whether they're bothersome or not, you need to know what they are. And knowing about them, our data shows that patients do better if they know what they are, whether they're trivial, have no consequence, or major. Just knowing about them gives you a better sense of control and management.
Great.
Rick, are you okay with that? Did I answer that question?
Oh, yeah. But I also would like you to say something about the time period that you spend on ADT and how that might affect.
The side effects is certain ones are cumulative. If you're not doing anything to load your skeleton, osteoporosis progresses over the time. 6 months, you're not going to pick it up particularly. A year and a half or 2 years, you might. You're low enough that they're probably not going to put you on long-term ADT. But again, that also what will then happen is what's your PSA, some months out. Obviously, if you get good control, we'd expect that of your PSA, they'll probably suggest short term. But I don't want to. Rick is absolutely right. How long you're on it puts you at greater risk. However, either way, 6 months is enough to get you, to affect you but negatively. So you should, whether you're going to be on a long term or short term, you shouldn't think, oh well, I'm only going on short term. I'm not going to worry about the side effects. That's sort of. I'm looking at Rick on my screen here. That's my other side of point. Yeah, they do. Ones like the cardiovascular risk, metabolic syndrome with the risk of cardiovascular disease and diabetes as presentations. Those progress with time. 2 years or more on these drugs, you're going to range of the 50% probability of serious problems, be it osteoporosis, diabetes, and so forth. So don't, even if they say it's only short term, manage it. Manage it by knowing what to do and taking it seriously, lifestyle intervention. I think I've said more than you wanted. Rick, did I at least give you the answer you're looking for? Good. Okay.
Thank you. Thank you very much.
Can I ask you a question, Richard? I haven't read your book, but I'll look for it. What do you think of prophylactic metformin? I've been taking 500 BID to prevent.
Okay. Hold on a minute, Jack. Jack, time out.
No question. Okay.
It's a fair question, but I don't want to run right off of this track. We've got to finish. Let's finish up with
Sure.
and then you need time because you have a good question for Richard. So we'll add you to the list if we may.
Question just came up. Okay.
Hey, Dan, you have your hand up. What's on your?
Alfredo, I started
Yes.
Casodex, my hormone therapy last week with Casodex, and tomorrow I'm starting my Lupron. But the thing that I really wanted to point out that I'm surprised nobody else did, my urologist is also doing the lab work every 2 weeks for the first 2 months to check on the liver, etc. Make sure that's getting done along with the PSA test with the blood work.
Well, apparently, my interpretation of this latest email is they're going to run labs after I've been on the 2 drugs for a month.
I would push for the first 2 months, get it every 2 weeks.
Okay.
More the better. And once you settle down, then every month.
All right. Thank you.
Jeff Markey?
Yeah, Richard, is osteoarthritis another one of the things that is causes by ADT?
That's a very interesting question. Some lists would say arthralgia, joint pain, and so forth is a side effect. If you look at most of the literature and most of the drugs, it's not a strong association, and I mean it's listed as a side effect. However, the catch is if we don't know whether those patients who have reported it were not exercising at all, and we don't have information on that. I do not see it in the hundreds of patients I've talked to as a common presentation for people who already didn't have either osteoarthritis or arthritic pain ahead of time who were exercising. And exercising both reduces the immunological response. So it's manageable, but whether it's a distinctive side effect, it's a low ranking one. The majority of patients do not report it who do not already have some muscular or skeletal pain. That's my impression. Did that answer your question?
Thank you.
Thank you, Jeff. And so we're going to go off into a little section now, see if for people have questions for Richard. Do you want to ask yours now, Jack?
Okay. I'm wondering how your thoughts about metformin prophylactically. I've been taking 500 BID because I usually run a FBS, a fasting blood sugar, of 85. It's popped up to 100, 101 since I've been on doublet therapy for over a year. And I just wonder if you have any thoughts about metformin and what the dosage
Yeah. So last time I looked, there were something like 11 different studies. And this is almost like 2 years ago. 11 different studies looking at prostate cancer and metformin. They were trying it in every which way and at every time. Could we, if you just start on metformin, does it slow the presentation of the prostate cancer? Does it show the progression of prostate cancer? Does it show a chance to go from active surveillance or sustaining active surveillance if you're on metformin? Everything suggests that metformin is a really good drug to control diabetes. It has yet to be shown to be positively helping control prostate cancer directly, despite all these trials, and many of them are still underway. So there's not been a major breakthrough, but there's no evidence at all that it is a bad drug. And what's sort of getting interesting is Ozempic and the new expensive anti-diabetic drugs are showing to be helpful for brain function, diabetic control, obviously for diabetic control, weight control, and there's at least one study I know in Canada looking at those earlier, one of the newer anti-diabetic drugs for prostate cancer treatment. Because clearly, if you can keep your weight down, that's a good thing. So we're going to see, I think, a lot of interest in that. I don't think you have anything to worry about being on metformin. I think it may be beneficial. It has not been shown in a major way. But if you want to discuss this with your physicians, you might ask, do you think there's any collective advantage in my moving to, if you can afford it, the more expensive, newer diabetic medications?
My question had nothing to do with whether or not it has an effect on the prostate cancer. Neil Fleischner, who I know fairly well, just did a seminal study on the fact that it is not very effective for prostate cancer. My question to you has more to do with the effect on my fasting blood sugar.
Oh, all right. So that's a diabetic regulation. So I'm going to call that a medical question that you need to discuss with your doctors, with your diabetic specialist. But I don't think it would necessarily. But you need to look. You need to look to see. Essentially, you're asking me how well is your metformin controlling your prostate cancer?
I never asked that question.
How well is it controlling the diabetes?
I don't have diabetes. I just want to know whether it's. I asked if it was prophylactic for incipient prediabetes.
Okay, so that would be Neil Fleischner. By the way, I have published two papers with him, but so have 1,000 other people. Yes, the early use of it as a prophylactic agent has not turned out to be effective. So what you need to know is, are you still at diabetic risk, and how bad is it? So that's actually, you need to get the blood sugar measured and/or the H1AC. I mean, your measures of diabetes, and that's a medical question that is individual, and I don't have a collective answer. I would say you got to go back to the doctor and ask to get some tests.
I could comment that at least in my case, my team waited until my A1C after getting on Lupron went up to 6.4 or 6.5. At that point, put me on metformin, only 500 milligrams a day, and the A1C went down into the upper fives. I got good control of my prediabetes by being on metformin, but it has made sense to me. It didn't get started until I actually had a diagnosis. Because it's a pretty safe drug, but it's not 100% safe drug.
Well, my A1C is normal, but my fasting blood sugar popped up, so I've been taking 500 twice a day prophylactically because my medical oncologist kind of likes the idea. He thinks it's a good drug anyway for longevity, but I'm taking.
When I first got started on metformin,
no side effects.
Yeah, when I first got started on metformin, my oncologist was pleased because back in those days there was a lot of intriguing, poor evidence that it might actually help prevent recurrence. Now, like as has already been said, You can't expect metformin to do that job. Anybody else got any questions for Richard about ADT before I move on to the next person?
Hey, John, did you try changing your diet a lot in order to stop and to not need metformin to get your A1C back down? I found that worked for me. I changed my diet a lot.
It's so good for a physician to hear someone raise a question like that, because the tendency is to look at a lab test and then slap in a medication, when actually a lifestyle change might actually do the trick. So I'm really gratified to hear a question like that. I did. My diet was good. Yeah. Okay, at the present time, if there's no more ADT questions for Richard. Oh, Richard, did you want to tell us something about a new way to afford ADT?
Well, I was going to make what I'll call a teaser. And the, where I am following, as I did a presentation for AnCan about 3-4 months ago, I am following an unusual procedure. I was on Lupron. I did not like the side effects, and I am now on high dose estradiol. It's out there on the internet. This was something of a mistake because I'm getting people from around the world asking me everything they possibly can about high dose estradiol. But once here we stand with this, we're waiting for. I'm following what's one arm of a complicated platform trial in the UK called the PATCH study, PATCH, and it's named after transdermal estradiol patches like the women use for menopause. So I and another patient have been looking into what these patches cost, how effective they are, what do we know about the serum estradiol concentrations against the data that's available for all of the patches and for gels and so forth. This is all in anticipation of this big study in the UK, the PATCH study, showing that it is an effective way of controlling the androgen production. The study, the PATCH study, is a head-to-head comparison of drugs like Lupron against high-dose transdermal estradiol. And I can say right now, but just if anybody's thinking about this, stay with whatever you're on. I'm not pushing this. It has not been approved. And it can lead to breast development. And one should not be using it if one has estrogen-sensitive cancers, risks in their families, and so forth. However, enough people are exploring it, both in high and low dose. So I'm anticipating that it's going to come forward and be shown to be effective. Then what will happen then? Well, it turns out that estradiol is a natural hormone. No drug company can get proprietary access to it. It means that it's effectively going to be very cheap because they're not going to. I mean, it turns out it is cheap. It's remarkably cheap. And then when you start looking at some of the older literature on how you apply it, when you apply it, whether using these patches or that patches, it turns out that this will be a lot cheaper than drugs like Lupron, Zoladex, Eligard, and it's going to be a way lot cheaper than Orgovix, which is not even available in Canada because it's so expensive. But I'm not going to promote it. I just want to, this is, as I said, teaser, because first of all, the PATCH study has not come out with its final results. So, and you will not get most doctors in the United States putting a patient on high dose estradiol when it hasn't got FDA approval, and you could end up being sued and so forth. So I don't know where it's going to go, but I'm amazed from the data we have so far that even amongst the patches, which are, there's a whole bunch of them on the market, is how different they are in serum dose and how fast the estrogen is picked up and the instructions on where to apply them and when to apply them. And all those little details, which I didn't think were important, turn out to be important. And that's I think, is my teaser. I hope it was interesting. I think the bottom line is, let's see where this goes over the next 5 or 6 months. John, was that okay?
Jerry
I just like to say one quick thing before we move on, and I'm putting in the chat window right now a webinar, not a webinar, it was a discussion with a few gents who were very interested in estradiol that we had on May the 9th with Dr. Wassersug, and it was recorded. And if you want to learn more about a lot of the issues Dr. Wassersug is just talking about, it's I think about an hour long, and it's worth a listen. And I'm putting the link in the chat window for you.
Thank you. Gary
Uh,
Grimes.
I do want to say one last thing because I've been besieged by people who, and this is the sad, the people who said I've read on this chat list how terrible the side effects of ADT are, but now I seem to have meds and I now need to go on ADT, and I cannot recommend this as a last line ADT. I almost want to go. I almost feel like I'm going to start to cry because I've been overloaded with people from around the world who have tried to avoid ADT for as long as possible. And there's no evidence that this is going to be any better than any of the approved standard ADT agents. It's not a miracle drug. It interrupts the standard endocrine regulatory system from the brain to the gonads. It clips it in a different place in a different way, but it's not a miracle solution. And don't please go to your doctor and say, I'm not sure I like Lupron. I want to try transdermal estradiol. Stay with what your doctors recommend at this point, please.
Thank you. Gary?
Yeah.
One more
Yeah.
time.
Try again. A related question, Dr. Wassersug, are you familiar with anyone looking at implanted estradiol pellets for a higher dose, long-term dosing?
The Scandinavians did, almost going back 25 years ago. Transdermal was explored. It's not quite clear there's an advantage to it, but there was. I don't believe anybody in North America is using it, but I don't know. But and I don't even. I think in I can't believe it was so. Can't even remember it was Sweden or Norway. I think it's still popular or still used there. So it isn't. I think it's still available. I would consider it more painful. I use the gel product as opposed to the patches. It's so easy to put on. So I would not myself be interested in a subdermal pellet.
Jeff, last question before I move on.
I listened to your webinar until you mentioned the fact that if you have BRCA2, you cannot use estradiol, and I didn't mention that today.
Yeah, that's right. If you have an estrogen sensitive form of prostate cancer anyway at all, or high family history of breast cancer, estrogen sensitive breast cancer, you shouldn't be doing it. So it's probably, but I mean, nobody should be doing that because it isn't even approved and the patch study isn't finished. But assuming the patch study is positive, I would still say genetic screening should be explored before one goes on high dose transdermal estradiol.
Julian, are you there? I only see your background. Let's go to Jeremy, and then I'll go back to Julian.
Hi, guys.
Hey.
Hi.
I'm 65, 3 years post radical prostatectomy at UCI, and recently had a little uptick in my PSA. And with the help of AnCan, I got in to get a second opinion with Dr. Keyshawn at UCLA, and have an upcoming appointment with Dr. Rettig in about a couple weeks. With the appointment with Dr. Keyshawn, I'll just update you. Since the most recent PET scan was negative for any type of metastases, and my PSA appears to be declining. It was up at 0.17, then dropped down to 0.14, and then recently I just got it literally a couple days ago. It was down at 0.12. Now this is following what's happened over the last 3 months. I lost my dad. I lost my mother, and I changed my diet dramatically. I started taking my diabetes medicine, which I basically had gone off of, but I started taking my metformin, curcumin, and berberine and vitamin D. I increased my vitamin D, and my PSA has fallen. You know, initially they thought it might have been within the margin of error, but now they're saying it's not. So they're actually having me do another PSA test. They basically don't want me to do anything until the PSA reaches 0.2, is what I was told. And if they do, they're preparing me. Dr. Keyshawn is preparing me to be a candidate for SBRT. Is that right, Rick? It's the 5 radiation treatments. And then because my what is it? The genetic testing showed that I was intermediate risk. He said that I would be a candidate for the SBRT and the Orgovix combination treatment. But we have to wait and see. He wants to do an MRI once the PSA goes back up again to at least 0.2. That's what's going to trigger the MRI, in his opinion. And that's kind of where it's left at right now, just waiting for the PSA to go back up. And that would trigger getting an MRI. And he did send out a swab test. It started with an M. I can't remember what the name of it was, Morbirex or something like that. It must be some type of gene testing. And that's where I'm at. Oh, I'm sorry, I can't hear you, Rick.
The swab test he sent out, I'm certain, begins actually with a P, and I forget the name of it, but it's the test to see how sensitive you are to radiation.
Ah, okay.
Do you remember what John, they talked about it last night several times.
Prolaris or something like that?
Say it again?
Prolaris or something?
No, Prolaris is a different one, but it's something like that. It's a test they do. It's very much at UCLA because that's where it is, and it looks at sensitivity for how sensitive you're going to be towards radiation, and it's mostly the guys that are going to go into radiation treatment initially that they will do it. I can't remember the look. I'll look it up in a second.
Yeah.
My question.
Oh, Prostock.
Prostock.
I think you're right. Yes, that was it.
Prostock. Thank you, John. Prostock. That's the one. My question to you is, he's talking about 5 sessions of SBRT, but what's he going to shoot? What's he aiming at?
Right.
We don't know where it is.
He doesn't know yet. So that's why he said we got to basically get everything in order. He got me in to get a colonoscopy. So I'm getting a colonoscopy tomorrow, actually Friday. And he wants to just get me prepared.
Okay. Be prepared. He must be a boy. He must have been a Boy Scout earlier on in his career.
and so he said the trigger for the MRI, and I did bring up the MRI PET, which you guys have brought up before, but he didn't seem to indicate that's what that he would do, that he would just get an MRI.
No, it was the MRI PET. There's no MRI PET. It's a PSMA PET, which you had. Didn't you have it? You said you had a PSMA PET. So the thing to do at this point is probably to repeat that PSMA PET when your PSA gets to 0.25 or somewhere around that. And maybe do an MRI as well. I don't know. Len, you're good at this stuff.
What's the issue, Rick?
The issue is nothing showed at 0.12, and Dr. Keyshawn wants to put Jeremy, back on.
Point one. It was at 0.16 actually when they took the PET scan or the PSMA scan.
Okay, so there was nothing showed at 0.16.
Yeah.
And Kishan is recommending active surveillance for recurrence, and they'll scan him again. And I'm saying to you, if he got scanned at 0.16, what sort of scans and at what level would you be thinking they might contemplate?
I thought I heard him say MRI is what he was looking at. Is that right?
That's correct.
Yeah.
Yeah,
I
Keisha
suppose
did-
he's thinking possibly this is a non-PSMA producing lesion, so he wants to try another form of
Yep.
scan. Yeah, 0.2 sounds like a good starting point. I mean, I was at 0.16, no, 17, when they did a PSMA scan on me, and it picked up quite a few lesions. So, everybody's different.
And in my particular case, Jerry, I'm also slowly recurring, but they're waiting for 0.2 in my case also.
Mm-hmm.
I think it's a common number.
And the other thing to discuss with him, but I think you probably would have to get a little higher, is an Axumin scan in the event that he thinks that you don't produce PSMA. So Len raises a really good point. He may be wanting to switch over to see if he sees anything on the MRI, because you could be a non-PSMA producer. There are probably 10 to 15% of people don't produce PSMA.
But if I produce PSMA on earlier scans, is it?
Did you?
Yeah, when I had an earlier PET scan before I had the radical prostatectomy.
Oh, okay.
PSA.
Well, then then that takes that theory out the window. If you do produce PSMA, Len, when do you think? Well, any thoughts that you have on when they should scan again?
Well, it didn't show anything at 0.16, so who knows? Maybe 0.3. I don't know.
Yeah.
So your first PSMA scan was 3 years ago?
No, it was basically undetectable until about 6 months ago, and it had ticked up to 0.17, and then it's been dropping since.
But you said you had a PSMA scan that was positive at one time before this one.
It was negative. Oh, before my radical prostatectomy, it was positive. It showed, spots in the prostate.
Oh, in the prostate. Okay, only.
With some extracapular extension involvement.
Okay.
And my Gleason was 4+3, and my whatever that genetic test was, I don't know what the name of it was, but it was something that Keishan asked me the name of, and I got it for him, and it said that I was intermediate risk.
What might that have been, a Decipher or something like that?
Decipher, yeah, it was Decipher.
Okay.
Yeah.
Okay. So we good for now? We're gonna wait a little bit?
Yeah, I guess basically I'll just get everything out of the way, so if and when the PSA ticks up, and like you said, Rick, I'm sure he's probably gonna want to do another PSMA scan, if not the MRI. So I guess we'll just go from there. I'm going to actually visit with Dr. Rettig in a couple weeks, and I guess we'll see what he says.
Mm-hmm. I'm sure he'll agree. Right now you're not really into his area, but we're getting you set up for when you are. That's really more the point. And this is
Yeah.
an interesting conversation. I know you've got a couple of other people to go to still, John, but this is a very interesting conversation for our old buddy Jay Mills. It's lovely to see you in the group, Jay. But I'm sure you're paying very close attention to this conversation, are you not?
That I am, yes. I have I've dipped in occasionally and watching you guys on YouTube, and but I have not participated. I was here several years back and have been undetectable since having HDR with Mac Roach and John Shue at UCSF, and 22 months of ADT, 6 months of abiraterone, and again was just doing with my had asked my urologist, his name is Mullins in Chattanooga, who was educated at Johns Hopkins, young fella. He I'd asked him to do a more sensitive test, and he said, "But we're not going to do anything. We'll just do the standard test, and if you show up something, we could do some switch up then." So we met with him, test on Friday with a zero point 0.1, which is the lowest detectable measure that it would give. So I'm somewhere between 0.5 and 1.5, which is a huge range. So I've asked him, he said, come back in 6 weeks, which is what Rick thought would be the best. I talked to him earlier today as well. And so if, um, so in 6 weeks, early September, I'll do another test and have it done with ultrasensitive. So we'll be able to start monitoring the progression and see if it's like, um, hopefully like Lou, it will be going downward. So we'll see.
So, we tend to think, and I sent the same paper to Jay that I think I sent to Jeremy by Dr. D'Amico that suggests about 0.15. It's not bad to start looking at 0.15, although the old wisdom for the PSMA test was probably higher, between 0.2 and 0.25. So, it's probably worth a shot based on the D'Amico. Excuse me, I have to apologize to my Italian friends here, Dr. D'Amico, Dr. D'Amico,
Amico.
and Dr. Carroll, because Peter was the other senior author on that one. To start looking at around 0.15, you may not see anything, but what their experience from looking at many of these scans has been, I think probably a lot of it was when they were doing the Osprey testing to get it approved, is that there are a few people that show up at 0.15, and if we can catch them, we can make a big difference. And so that's why we say, man, now get a PSMA scan at 0.15. If nothing shows, as in Jeremy's case, we'll do it again at 0.3 or whatever it is. But if we go ahead.
No, I was going to switch topics, so finish your sentence, please.
Oh, I was just going to say, I mean, God forbid something showed up at 0.3, then knowing Jeremy as I do, he'd make himself crazy that he didn't do the scan at 0.15. Yeah. And he'd be beating himself up. Why didn't I check at 0.1? Now, again, God forbid something does show up at 0.3, he'll know, but it wasn't there when I was at 0.16. And so you have that, it's an anxiety management thing as well, as much as anything.
Have no regrets. Live your life so that you have no regrets.
Yeah.
Okay, Dr. John, go on. Let's keep going here.
Okay, Julian, I want to give you some time before we close.
I see Dr. E tomorrow. My blood work came back. The good news is my PSA is still in the dirt. undetectable. Just a side note on that, they did an ultrasensitive back in April, and it was 0.014. So she didn't do it this time. So I'll ask her about that. But the other side of that, my testosterone has dropped down to 75 now, so I'll ask her about that too. So and then my A1C has jumped up to 6.3. So, but I'm on metformin, so that's it went from 6 to 6.3. So we'll see.
It went up while you were on the metformin?
I wasn't very religious about it.
Okay. Now you'll be more
Now I am.
now you'll be more religious.
Yes, I am.
And I had another question. Can you tell the difference? You said your T was 75. Can you tell
Right.
the difference between 75 and whatever your previous one was, 100 or whatever?
The previous one, let's pull it up real quick. Was
149 in
yeah, 149.
149 in January.
Thank you, Rick. Can you tell the difference between 149 and 75 and how you feel?
I don't feel as active. I feel a little, blasé, if you will.
Yeah.
So I thought it was going to turn around and do better, but apparently it didn't like me.
Okay.
So,
You're right on the verge of castrate now.
So
Right.
what I would discuss with Dr. E is first of all, my question to you, were these two testosterone tests taken at the same time of day?
Good question.
I think so. It was 149 in December, and then April it was 107. So it dropped
Okay.
down from 107 to 75. So I'll ask her about that. She didn't want me to take any, testosterone at the time. So I'll ask her what she wants to do on that.
So it's been patterning down.
Yeah.
Yeah. But
Well, it was at 155 back in a year ago, and then it went down to 127 and up to 149, then down to 107, and now it's at 75. So I don't know, but I do
well,
exercise quite a bit.
no, I'm sure you do, but I know that there are a number of docs we work with, and I probably would put her on the top of the pedestal on this one, who are very concerned about their patients' quality of life.
Yes.
So when they make treatment decisions, they are keeping in mind what those treatment decisions are going to do to quality of life. And Dr. E is really good about that. And so I tend to think that if there is a way, she's smart enough that if she thinks there may be something else playing in here to affect your testosterone, she's going to get you tested for it with a different type of doc. And if there's an opportunity to supplement, she'll talk to you about it. Probably not in your case, but maybe. And if anybody's going to supplement it, she would be one of the docs I would expect would. So, anyone else here who's wrestling with this persistent low testosterone when they are not on treatment? Because you're still on a holiday, correct, Julian?
Oh yeah, I'll be 2 years in October.
Right. Anyone else wrestling with that issue? Dr. John, speak up, please.
2 years also, and I'm at a T of 50. So you can see why I was so interested in your perception at 75.
And what do your docs say about that, John?
Too bad. Live with it.
Well, I'll tell you what Dr. E tells me in 2 weeks.
Okay.
Let me ask you a question, John, Julian. Were you both metastatic or were you not metastatic?
De novo metastatic in my case.
I was not metastatic. It was all confined to the gland.
Okay.
Okay, guys, we're about done. Thank you for a really interesting group with a lot of unusual symptoms, side effects, treatment decisions, things like that going on. Thank you,
John,
Richard, for coming in. Rick, please.
yeah, we have a little. I have a little bit of time. Dr. John, feel free if you have to go. But I know Michael McCabe came in late and Keith Hilton came in late, so I just wanted to check in with them and see if they needed anything, because we can take care of you because we're done at 5 o'clock, which doesn't often happen, and we no longer have a meeting following us in this room, which is a good thing. And Jeremy has a question, but let me first go. Let me first go to in the order they came in. Keith, is there anything you'd like to talk about? You're muted. You got to unmute first. There you go.
Oh,
We can't hear you. We can't hear you. Oh my gosh. I wonder if, I'll tell you what, I'm going to go to Michael. Check your settings and make sure that the microphone you're using is the one that is identified in the settings. We'll come back to you. Michael.
Yes. All I want to say is I'm changing teams and I'm going down to UW-Madison to the Carbone Center.
Yes.
And I'm, prior to that, I told you, I don't know if you remember, Rick, where I said I was just going locally to Aurora.
Yep.
It was called the Lombardi Center. But I just feel like I need to up my game. And that's where I'm going to start then or continue. And then we'll see how that goes. I just feel like I want a team with more experience and stuff. There's been a couple of things going on I didn't agree with, which I'll bring up at another meeting, not right now. And when is that coming up, Lori? At the Carbone? August 19th. Going down there, and I will ask this question, Rick. I'm not sure if you know anybody there really at the Carbone Center, but if there is any kind of recommendation to anybody there, I would appreciate that. So
Josh Land, Land. Lang,
okay.
Lang.
Oh,
Josh,
okay.
okay.
Yes.
We've had,
My care partner here, my wife, she's getting that down right now, Rick.
okay.
So
So
thank you.
Dr. Lang is very, very good. Very,
Okay.
very good. And if you
Okay.
cannot see Dr. Lang, hold on a minute.
I'm listening.
I've got to, there's another guy who we know of there. And I've got to see if I can find him. John Streslek. Glenn Liu, Liu, Glenn Liu, Liu.
Oh, okay. Rick,
Yes.
I do have an appointment with him. Is he
Okay.
okay? Is he okay?
Yes. Yeah,
Okay.
he's good. I probably would go to Lang because I think Lang is he's more of a researcher, so I
Okay.
know he's on the cutting edge. He's done a lot of
Okay.
great research. I
Okay.
think he is a medical oncologist, but he's double qualified in something. I've got a feeling he's really strong on the radionuclides. So,
Okay.
if you could get in, if it were me and I could see
Okay.
Dr. Lang, I'd go to him. If you couldn't see Dr. Lang, I think you're fine with Dr. Liu.
Okay. Well, you know what, Rick?
Lang's a little
I'll,
younger, I think, and more with it.
okay, so Rick, what I'll do is I'll check with that, Dr. Lang, and then as a fallback, Dr. Liu, what I'll do. Does that sound all right? That's what I think that I'll
Yeah, but, definitely. And once the other thing I'd like to say to you is if you're moving your care to Carbone, make
Mm-hmm.
sure you avail yourself of all the good things they're going to have in that comprehensive cancer center. They'll
Yeah.
have a lot of good stuff there. They'll have a registered dietitian that you can meet with. They may have somebody for exercise.
Excellent.
They may have a integrative cancer center, which
Great.
will deal with a lot of the holistic stuff.
Okay.
And I'm not certain it was Carbone, but I think they probably do have an integrative center. But all of these are usually very accessible at no cost to
Okay.
patients that are at a comprehensive cancer center like
Excellent.
Carbone.
The other thing I was thinking, Rick, is mental health. I have a depression issue as well.
Right.
So maybe I could also um, avail myself to that possibly. I don't know
Okay,
if it would.
so let
Yeah.
me defer that one to Dr. John. Dr. John, how would you integrate the mental health aspect for Michael, for Mike?
You see what they have. I like the idea of seeing a mental health specialist in an integrated cancer center if possible. See if they have somebody and have a
Okay.
consultation.
I don't.
Otherwise,
Yeah.
just go to the community person.
Okay. I don't
Oh,
really have anyone now. I think I did say that before that
Yeah.
I just have a general practitioner and I need somebody. I have a long history of with that, and that affects everything else, right? So,
Oh,
you
yeah.
know, so
here's what
anyway,
you do. Here's what you
hey,
do.
I'm listening,
Because
Rick.
you're entitled to do
Yeah.
this. Make an appointment with the palliative care group.
Okay.
Okay? There will
Hmm.
be, I don't know what they'll call it. Like at UCSF, they call it symptom management. And at different places, they have all these acronyms for it. But you be sure to make an appointment. And, you can tell them that you're dealing with these advanced prostate cancer issues,
Hmm.
and they will lead you into the right care for the mental health. Do you think
Wonderful.
that's a good idea, John? Through palliative care?
Sure, excellent, because they'll not understand your situation. I'm
Okay.
always in favor of subspecialists. They know so much.
Well, John, I need the help. So, I think you guys got the wind of that. With a couple of my times have been on here, I broke out in tears and, stuff like that. So, you know, I want that to be better in control, and so does my wife, obviously. So,
Yeah. I would definitely say venture into that through palliative care. I
okay.
think that would be really helpful. Are you on any treatment right now? I can't remember.
Um, right now, all I'm on is Firmagon.
But you
Yes,
are on Firmagon. Okay.
yes, I am. But
Yeah, that'll do
basically,
it.
you know, okay,
That
that's
will
Uh,
that will do that, and that's enough to get. That is definitely enough to get palliative care's attention, and
okay,
to go to palliative care, tell them that you're on an LRH antagonist, and you're
okay.
wrestling with depression. Richard, you want to say something?
we have 2 chapters in the book which deal with the psychological impact of these drugs, and there's both lifestyle stuff, but I would recommend you take a look at the androgen deprivation therapy book, because again, it can be managed. What are you doing for physical exercise these days?
Um,
Because
well, we just went for a 3-mile walk tonight, my wife and I, but I haven't been doing much in the way of resistance at all. And I will say that I go into these depression funks where then I don't do anything for a couple days, and which I know is not good. And
So
so,
Pharmagon has that risk. And again, I'm only speaking to the lifestyle interventions, although there's a lot of the MDs who put patients on these drugs ask right up front, if they're on antidepressants, whatever. If you have a history of depression, it can make them much worse. But physical exercise where you're not just walking, but you're getting your heart rate up, has been shown to help with the depression and fatigue, insomnia, and depression are three classic things that come together. These drugs, they're cancer in general, but particularly with the nutrient deprivation therapy treatments. So I recommend the book. I agree with what they said. Talk to the doctors, see if you can get a specialist attention, and push yourself a little harder unless your skeletal system or the doctors say you can't on the exercise. Don't let it go for a couple of days. Fight it. Be active.
There's one more issue I'll quickly bring up because I don't want to monopolize the time that's left, okay? So Rick cut me off when needed. I just want to bring up one more issue, and it's this here. So did you see that?
Yeah, I saw it.
So, yeah.
Get rid of it.
Yeah, well, that's another issue I have. So,
but please discuss that when you're with palliative care. Please discuss it.
Okay. So that again, it's a family history and it's with me, So I mean, I've got more than one area here to take care of, and I never brought that up before, but I'm bringing it up now. I know. I'm sorry to bring it up.
I think it's really important to discuss that. As Dr. John knows, in a different situation, I have been in the midst of an issue, and I'm not suggesting this is you at all, but
I understand.
Been in the midst of a drug addiction intervention over the past several days. I think it's really important, and this was a big problem in this drug addiction intervention, that the doctors for this person weren't on top of what was going on. So you must mention it. And with palliative care, please tell them. I will tell you, I have a history of chronic depression. When I went on hormone therapy, Lupron alone, back in 2008, the end of 2007, November 2007, I started. I was already medicated, and when the black dog came to visit, I went to my PCP, and he suggested I double my dose, which I did, and it worked, of the antidepressant drug, and it worked great. And then when I felt better, I would pull that dose down. So I managed the depression impact from the hormone therapy by playing around with my drug dose.
Okay.
So please make sure, get to see Dr. Lang or Dr. Liu.
Okay.
Definitely make an appointment with the dietitian. If they've got any exercise support at Carbone, seek it out, and absolutely seek out an appointment with the palliative care. I mean, you are a long way from Carbone, right? 3 hours?
Is it about there? 2.5 hours. It's no problem. No problem.
You just try and get stuff scheduled so you're not running back and forth every 2 minutes. Okay.
Yeah. Okay. Thank you.
Okay.
I don't want to take up all your time.
Okay. We'll move on. Let me take Jeremy's question before we go to Keith Hilton. Go ahead, Jeremy.
We sort of talked around it just a little bit, but and maybe it's for another topic, but in terms of nutrition, by the way, I can't emphasize how important the exercise is. And Michael, I would implore you, as many of the others have said, to just go in there and go for it. But in conjunction with that, I wonder what the thoughts are on the group in terms of nutrition and use of supplements, whether it be lycopene, curcumin, berberine, vitamin D.
Excuse me, Jeremy.
Yes.
A great topic, but we're over time.
Okay,
We could
that's
talk
fine.
about we could talk about supplements for a long time, so let's not do it tonight.
Thank you.
But
Thanks,
but
John.
but come
sorry.
back
I'm
in.
sorry.
No, I thank you, John. Come back in and raise it, and we will talk about it. Okay?
Thank you.
Absolutely, absolutely. It's a great topic. Dr. John writes about it from time to time. If you didn't read it, make sure you read what Dr. John wrote about soy. Very, very good in this last in the last reminder. Okay?
Keith, let's just make sure Keith doesn't have anything pressing though
Yes,
before
can we hear you, Keith?
Are you okay, Keith? No, still can't hear you. Keith, can you hear me, Keith? I don't think he. Oh, you can hear me. Okay. We can't hear anything. Come to the next meeting. If it's anything can't wait till then, send me an email. Okay, guys. Good night, everyone.
Good
Thanks
night.
all. Night.
Good
Good
night,
night, good
Bye
everybody.
night,
now.
good night.
Thank you.
Good night, good night.